Thank you for the opportunity to present and to share a little bit about our journey in supporting academic or really community university partnerships. And so with that, I'm going to talk about building community capacity and the opportunities that we've had to contribute to change and improvement in communities. And so with that, at the Work Group for Community Health and Development at the University of Kansas, we promote partnering with community-based groups from grassroots neighborhood-based organizations to state and local departments. But what's common in core is enhancing the capacity, the collective skills, capabilities, and resources of individuals and groups in the community to come together to support change and improvement. I'll note and give you a little caveat first. I talk pretty fast, so if I start to go fast, let me see a hand. And the more excited I get, the faster I go. And the classroom apparently has not helped me in this area. My students usually think that they're going to get out early, and we still go the whole time. They get twice as much in one lecture. So, so with that, just very briefly, what we can expect through this 20-minute presentation is thinking about, first, I want to show you some of the pathways that we've had with working with successful and effective community-based efforts, primarily in the Kansas City metropolitan area. I'm also going to describe some of the frameworks that we use for collaboration and participatory action. Coming from a researcher and an academic perspective, the importance of the participatory framework will be described. Also, we'll examine the capacity building process, as well as explore the importance as well as the challenges of community university partnerships. So a quote from Margaret Mead: "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has." And so when we think about that, those groups of committed citizens, that includes us. That might be the neighborhoods that we live in. It could be the agencies in which we work, including institutions such as universities. It could be the organizations that we are affiliated with, including faith communities, faith organizations. But it comes down to one main thing that a community organizer in Kansas City, Kansas told me pretty early on in my graduate career, undergraduate when I was in graduate school, and that's how do we protect our best investment? You can frame that however you want to be. Your best investment could be your kids, it could be your business, but that's kind of where we come together in commonality, and then we think about how do we build the capacity to do so. So probably one of the earlier experiences that I had when I really started to try to understand this work of community capacity building was with the individual that you see featured in this article here. And this is an article from the Kansas City Star in 1997. And this is Alan Young, a community champion, and his 4 young children at this time who are now adults. But he was an individual who was a carpenter, lived in his neighborhood, and decided that he no longer had to stand for the ills that were going on in his neighborhood. And he, as one person, and his wife began to do things such as prayer vigils and just very basic activities in the community. But with that, they began to lock arms with other organizations, other groups that had some expertise in organization and mobilizing. And from there, individual by individual, they begin to build the capacity of this neighborhood that serves approximately 7,000 individuals in the Kansas City area. And they locked arms and built the capacity, and we came in as a technical support provider, an academic-based technical support provider, to begin to provide the training, the skills, the capabilities that were needed, so that now they have been sustained for over 17 years from the efforts of one person determining, hey, I'm not going to take this in my community, there's something that we can do. And so with that, just showing some examples of, in that time, in the late 90s, some of what they were seeing on a daily basis. This neighborhood was in the heart of Kansas City. Highway renewal, urban renewal, stripped the heart out of the city, very common to many urban areas. And from there, what was left was quite a bit of disinvestment and quite a bit of flight from the community. So there were abandonment of buildings, crime, of course, disinvestment, poor living environments, vacant housing, squatting was pretty common. And so, once disinvestment gets into the community, we know what goes from there. And so this visual you see here is actually something some of my students did, and I just took it out of a digital story project they did. But basically, they were just demonstrating that from one person, whether that's from us as an academic base, whether that's from the individual who's in the community, health practitioners, whatever our base might be, we can all step up and lead, and when we do that, others will join. One of the key things that this group did and that we helped to support was adult development.
believe it or not, all the ills that were going on in that community, when they came together and we took them to the strategic planning process, adult development was their kind of #1 goal, meaning community education, training, capacity building activities to help those in the community to be able to come together to solve their own problems. And then from there, they were empowered to do and address issues related to beautification, related to crime, related to violence, related to housing. And so it was just that, leaving behind and working with community partners to leave something behind so that we could leave and have left, even though we stay connected in other ways. But they since then have updated their strategic plan and done a lot of other activities on an ongoing basis because of the ability and the capacity that they had in their community. And so, just to this example, they engaged over 100 block leaders, and actually it's more like 200 block leaders now, meaning individuals on their blocks that came together that are responsible for developing block level plans that work with their residents on their blocks to support mobilization at a very systematic but level of the block. They also have engaged in multi-sectorial partnership. So we, as the academic partner, we represent, of course, one sector, but businesses, government agencies, all schools, residents, parents, coming together to support change and improvement. Through that, they facilitated 117 community changes, program policy, and practice changes. We'll talk about in a little bit the importance of oftentimes us working with our community partners to be able to determine how the environment is changing, which is critical and key. But with that, then that has led to improvements in community outcomes, such as housing. During the 4-year period, they had a 54% increase in housing loan applications, meaning people wanting and willing to reinvest in their neighborhood, decreases in crime violence, as well as, this is just kind of showing they decide we're not going to allow people to dump in our community and some of these other things that were going on, which also then related to decreases in nonviolent crime and some other activities. They first had to address what was the most basic needs as named and framed by the community, by those living there. After they addressed that, so that was crime, that was housing, education, but after they addressed that, then they were able to begin to then move into, within this past decade, and looking at some of the more traditional aspects of health. So they have farmers markets. This is showing a playground that they have developed since then. And so I'm just going to go pretty briefly, just another example, working with the State Department in Kansas to address underage drinking. Same process that I'm going to describe in a moment, but contributing to reductions in youth levels of reported alcohol use. This was an initiative with 14 community coalitions in the state. With that, they implemented across these 14 communities 802 program policy and practice changes through engaging what we think of as 12 sectors of the community, and have now resulted in what has become a model in Kansas for how to support prevention work. We are at the table, but we're at the table as co-partners. Even though our role as an evaluator, we really kind of serve as partners as part of the process, and that's kind of the way that it should be. So we're not going in and saying what should be done as much as evaluation is a part of the culture of what's being done with these local coalitions as well as with the state. Also thinking about how to address health disparities, some of my colleagues, Dr. Stephen Fawcett and Dr. Carly Akers, work a lot more on the Latino Health for All Coalition project, which is really looking at addressing disparities in cardiovascular disease and diabetes in Kansas City, Kansas, based off of a model that they had supported about a decade ago in Kansas City, Missouri. And so with that, providing access to healthier foods, a lot of what we heard earlier, changing the environmental conditions so that play spaces are converted to other more positive and structured activities, providing access to healthcare are some of the activities that my colleagues are engaging with and supporting 41 program policy and practice changes over the initial 3-year program period. So with all that and with what we do, what are some critical elements for population level improvement? First of all, we have to have attention to outcome. So we have to be working with our community partners to identify the behaviors that need to be changed at the level of the community and the population. But then after we know the behaviors to be changed, so if that's we want less kids to drink, if that's we want more individuals to engage in physical activity, then it's important for us to work with our partners to understand and document how we're changing the environment. We consider that our ability to understand our contributions to these changes and behaviors. And then ultimately, we heard earlier, the change process is as important, particularly from the perspective of the community, as some of the outcomes. And so, based upon the IOM 2003
Collaborative Public Health Action Framework. This is the framework that we use with our community partners. It guides the process. Everything else in the framework is implemented based upon the direction of the community partners. So first beginning with helping our communities understand how to assess based upon what you're seeing in your community. We tell them you're the best researcher, really. You live here all day, you see what's going on. I go home at night, you stay here. So helping them to strategically think about how to assess, then how do you prioritize and plan. From there, how you implement targeted action. So how do we have systems and structures to mobilize? Ultimately, we want to change community conditions, which results in changing enough people's behaviors that we'll see in the middle population level health outcomes and improvements. And so what's core? And I'm not going to walk you through all this, but what we found pretty core is that for each of these phases, we've operationalized it with the processes that communities do or that they can engage in. So a lot of times we know that communities want to come together and they want to support processes, but it's kind of the how do I do it, right? And so with that, that 5-phase model, then in Ivanhoe, the Latino Health for All Coalition, Strategic Prevention Framework, even though it has a slightly different model, it implements the exact really same elements of understanding, first of all, how to analyze information about the problem and goals, how to come together around a common vision and mission, how to develop strategic plans, having a mechanism for operating or organizational structure, how to have leadership are pretty common. And so I won't walk you through all these. If you have questions, you can definitely let me know. But I think the key aspect is that when we as an academic partners, when we come, part of our responsibility is to support the ability of our partners to be able to implement these processes. So it's not us prescribing the process to them, but providing the supports so that they can implement the processes and maintain the processes. And so Abe Wandersman talks quite a bit about the prevention delivery system, meaning your coalition, your community partners, your prevention support systems, such as us, oftentimes taking the role of the technical support providers or the enabling systems, and then your prevention synthesis system, meaning how are you disseminating the information to others. So with that, when we think about change and improvement in communities, what we know and what we work with our community partners to think about is that we're really generally talking about comprehensive community interventions. That single dose interventions, while important, so one program is important, but the multiple and complex and interrelated problems that we want to come together to address usually requires an influx of program policy and practice changes, which we define as community systems changes. And we work with our community partners to systematically document those efforts so that they can say when someone says, hey, we see that you've had a reduction in intentional injuries, what has been your contribution? That they can understand their contribution is not about attribution. You know, it takes all of us and all our organizations and groups, but the contributions of our partners to support change and improvement. So systematically documenting program policy and practice changes and understanding how that relates to improvements in the population level or community level health outcomes. But what we've noted and what we help our partners in the community to understand is that you have to have change that's of sufficient goals. Meaning, if we want to address underage drinking, but all of what we're doing, not saying that it might not be important, in the community might be relating to reducing tobacco use or meth, that might be great and important, and if that's where the community has gone, maybe we need to go back to assessment. But are we targeted and focused on our goals? We need to have strategies of varying types, so it's great to provide information, and usually that maybe is a first early win, but we can't necessarily just stop there. We have to also have mechanisms of enhancing services that are available, of modifying access so that people can get to these services, changing consequences, so as well as changing policy and broader systems, that there needs to be activities of varying duration, and that we have to penetrate, meaning we have to go deep, engaging the right people, which generally are targets of change, can be our agents of change, as well as through the various sectors of the community, the different aspects in where people live, work, and play, through the places in which people are congregating. And so that's a little bit of what we work with our community partners to think about, to know, to understand, and from there they kind of take it and are able to do the work. We also support this participatory evaluation framework, meaning that we want to ensure that we're not coming in and it's top down, that's not it or the goal, but that we're working collaboratively with our partners. So that leaves it beginning with 12 o'clock, allowing our partners to name and frame the problems and goals in their words and their terms, framing it in terms of behaviors and conditions of the environment they need to change, identifying the research questions. So once again, we're not coming in as the academicians, but we're here at the table, but really what is it that you want to understand or explore? working with our partners to define what's the model for success, as well as systematic ways of documenting what you're doing, your interventions and its effects. And there's oftentimes a gap right there. We may have the logic model and we may know the behaviors we want to examine, but what comes in between oftentimes is what's missing, our ability to document our changes, our program policies and practices. Then using the data to make sense of it with partners is a part of what we do as an ongoing process. So we're at the table with the partners. We're not saying this is what it means. It's not our interpretation as much as it's your interpretation, meaning our community partners. What does it mean to you? How can you use this information? It's part of the ongoing process. So we're not doing summative evaluation, coming in at the end as the researchers from the ivory tower telling you it worked or it didn't work, but working with you on an ongoing, on a monthly, weekly basis to use the data to make data-informed decision-making along the way. And then lastly, the part that sounds the most exciting, but that we often overlook the most, is using the data to actually celebrate and make adjustments as a part of the ongoing process. And so with that, I'm going to probably skip over some values and assumptions, but some pretty core things is that we need to focus on improvements at the level of the population. We need to change both behaviors as well as conditions in the environment. Issues should be determined by those that are most affected. We should be looking at how to address social determinants of health, and after we address that, then it oftentimes will lead to other health behaviors that we might need to examine. That there are multiple interrelated factors that contribute to these problems, so taking comprehensive community approaches, not framing it as the researcher wants to frame it, but framing it as the community identifies it needs to be framed. So that could be safety, even though ultimately we might want to get to increased physical activity. Engaging diverse groups of the sector, so thinking about who's not at the table as much as who is at the table, collaborating with multiple partners. We also should be serving as catalysts for change, and then ultimately we should, be building capacity to address what matters to people in the community. So I think someone said it really a while ago. If we're doing our jobs and as the academic partner, then we should be leaving something behind. And we should be able to transition, even though we might be staying connected and engaged in some ways. And so I think I'm close. So the key thing that I probably want to leave is that this concept of community engaged scholarship, we talk about it quite a bit in academia now, theoretically, but I think we're hopefully moving to where it's more practiced. So that's where research, teaching, and service is all integrated into part of what is done. And when I say it's theoretical, it really probably is. So last year, I was going through a process and someone pretty much told me, you probably need to start to inform others a little bit more about how your work is community engaged scholarship. So we see you're doing a lot of service. How does that relate to research, and how does that relate to teaching? And so there are some disconnects, even though we can theoretically think about it, in regards to how that gets applied on the ground. So I'll just leave you with some lessons learned is that ultimately what we want to do is in the middle. We want to build trust and we want to build rapport with our community partners, which requires us to, if you go at 11 o'clock, to have commitment over time and across place. That could be a university commitment, which we do, but that could be across disciplines. We are very siloed. How do we infuse what we know across disciplines, across fields, to take the best of what we know to communities or to environments? Also ensuring that you have some early wins. So, it's hard for our partners sometimes to see kind of where we're going, so make sure that you're almost programming in for some early wins to build that shared success. The community is the expert, not the person from academia or the groups. I also didn't talk about it as much, but we do quite a bit with service learning, with engaging students in the process, with training students, with leaving behind through both direct and indirect service, leaving behind something in the community. And so with that, it's an infusion of resources. So not just material resources or grants, but also human resources. Human capital can really be as helpful to our partners in the community as sometimes the financial resources. Reducing barriers to academia, just having a presence in the community makes it much more accessible for others in the community to understand that academia is achievable, as well as to think about what they want to do and how they want to do it. I would say on the other aspect of that, though, reducing the barriers in academia for community-based researchers to support the process is also something that we need to continue to address. And then, ultimately, you probably might not see it very well, but staying at the table. A lot of times when we go in the communities, what I hear from partners is that, people have been here before and they never gave us the data back, whatever the case might be. But staying at the table long enough that you're not just the researcher coming in, but that you're actually part of
that community of part of that process. And so I'll just leave you with a little quote by President Clinton when he indicated, "We need to empower our people so that they can take more responsibility for their own lives in a world that is ever smaller, where everyone counts. We need a spirit of community, a sense that we're all in this together." So whatever our base is, we can all contribute to this process of change and improvement, and I think it is our collective responsibility to have collective impact and to think about how we can take our base, in this case from academia or from the institutional settings, to aid in the common good.
Thank you very much, Jomella. That was amazing. Our next speaker is Renee Kennedy. She recently transitioned from being the health director of the Ingham County Health Department to now Chief Executive Officer of the Michigan Public Health Institute. She is also an assistant professor at the Michigan State University in the College of Nursing. So welcome. Thank you.